Thanks for listening to this practice profile on the diagnosis of cerebral palsy in British Columbia, the impact on hip surveillance and parent experiences. I'm Stacey Miller. Over the next 10 minutes, I'll share with you some of the work that we've done looking at how diagnoses may impact enrollment in the Child Health BC Hip Surveillance Program, as well as work done to describe when and how parents are receiving a diagnosis for their child. As part of the hip surveillance program, we've done therapist surveys in 2015, 2017, and 2020. As part of these surveys in both 2017 and 2020, we've asked therapists to identify barriers to enrolling children in the hip surveillance program. You can see here the barriers that were identified as part of the 2017 and 2020 surveys. And I've just highlighted one for you. I think the child is appropriate, but they don't have a diagnosis of cerebral palsy. And that was identified both in 2017 and even more so in 2020. We were curious about this and so started to do some more investigating and did a knowledge and learning needs survey related to cerebral palsy of pediatricians in the province in 2018. The survey was completed by 76 pediatricians, of which 55% reported they were general pediatricians, 38% identified themselves as having a subspecialty, and almost 7% as being both a general pediatrician and subspecialist. When asked to report what percentage of their practice was children with cerebral palsy, 18% reported that 0% of children in their practice have cerebral palsy. 63% reported that only 1 to 10% of their practice was children with cerebral palsy. This leaves about 80% of pediatricians reporting that 10% or less of their practice is children with cerebral palsy. Of the 62 pediatricians that reported seeing children with CP in their practice, 65% reported seeing 2 or fewer patients with cerebral palsy in the average month. When asked if they were currently diagnosing children with cerebral palsy, 56% of respondents overall and 59% of general pediatricians reported that they were currently diagnosing kids with CP. Most agreed that providing a diagnosis was important and that early diagnosis is important for families. When asked who could definitively diagnose cerebral palsy, the most common responses were that neurologists, developmental pediatricians, and pediatricians could provide this definitive diagnosis. To look more closely at whether having a diagnosis of cerebral palsy impacts enrollment in hip surveillance, we looked at how children were being enrolled in the program. We do not require kids have a diagnosis of cerebral palsy to be enrolled in the program. They can be enrolled as having CP, as having possible cerebral palsy not yet confirmed, or as having an other condition. And so last year we reviewed all of the children that were enrolled, and at the time it was 959 kids. And you can see here that 64% were enrolled with a diagnosis of CP, 13% were diagnosed as having possible cerebral palsy not yet confirmed, and at the time of enrollment 23% were enrolled with an other condition. Between the time that kids were enrolled and the time that this review was completed, we were able to confirm that 75% of kids have a diagnosis of cerebral palsy, and that 5% of kids do not have cerebral palsy as they have a progressive condition that's not in keeping with the definition of cerebral palsy. We were unable to find any chart notes on approximately 2% of the kids that are enrolled, and so we could not comment further on that 2%. This left us with 18% of the kids that were enrolled where we were unable to confirm whether they had a diagnosis of cerebral palsy. These children had etiologies that were provided, and based on the literature, we were able to confirm that 7% of these were consistent with the definition of cerebral palsy. The other 11% we were unable to confirm. They had etiologies that that were complex, many of them genetic, and we could not make a conclusion. So this review has really shown that 1 in 4 children are enrolled in hip surveillance without a diagnosis of cerebral palsy or possible cerebral palsy in British Columbia. And it's unlikely that allowing children to be enrolled without a CP diagnosis fully removes the lack of a CP diagnosis as a barrier to accessing early hip surveillance. We would suggest that a provisional diagnosis of cerebral palsy should be given early when the clinical presentation meets requirements to ensure that children have access to services including hip surveillance. And this is really in keeping with the published evidence as well. This clinical practice guideline that was published in 2017 strongly recommended that a clinical diagnosis of cerebral palsy be made as early as possible, and that an interim clinical diagnosis of high risk of CP be given when the clinical diagnosis is suspected but cannot be made with certainty. A note here about the definition of cerebral palsy. It's defined as a group of permanent disorders of the development of movement and posture causing activity limitation that are attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. You'll note that the definition does not include the underlying cause of a child's motor impairment. And certainly understanding the underlying etiology is very important. And a diagnosis of cerebral palsy should not prevent understanding the specific etiologies involved. Nor should identifying a specific etiology prevent children from also having a diagnosis of cerebral palsy. Advances in genetic testing has really changed diagnosis as well. This 2019 International Consensus Statement from the International Cerebral Palsy Genomics Consortium did, however, recommend that genetic or other causation should not change the clinical diagnosis of cerebral palsy. And a recent review suggested that a potential genetic etiology may be identified in between 10 and 30% of children with cerebral palsy. Despite this recommendation, there still is high variability in the number of physicians that will diagnose a child with cerebral palsy when they have a genetic etiology. This study was published just this year in February of 2021 and surveyed 330 American and Canadian physicians with an interest in cerebral palsy. Only 67% of physicians would diagnose a child with non-progressive spastic diplegia due to a genetic etiology, and even fewer, at 46%, would diagnose a child with non-progressive hypotonia due to a genetic etiology. This is consistent with work we've done here in British Columbia. These are results from our surveys of physiotherapists in 2015 and 2017, as well as the pediatrician survey in 2018. And this shows that just over 70% of respondents in all of these surveys felt that a motor dysfunction from a genetic or metabolic cause could result in cerebral palsy. And so all of this work really does show that there's still work to be done understanding how diagnosis of cerebral palsy impacts access to services such as hip surveillance. Now shifting to parents, we also wanted to get their perspective on how they were receiving a diagnosis for their child. We aimed to understand at what age children were getting a diagnosis here in British Columbia and how they were receiving the diagnosis, including who was providing the diagnosis to them. So we did a survey, and it was completed by 180 different caregivers. They listed their child's diagnosis as cerebral palsy in 71% of the cases. Another 20% were etiologies that, again, were consistent with cerebral palsy. For 20%, autism 3%, a progressive condition made up 1%, and 5% reported they had never received a diagnosis of cerebral palsy or any diagnosis for their child. The mean age at diagnosis of cerebral palsy was 15 months and 19 months for all diagnoses. We thought that was quite low and quite surprising for us. They noted that the diagnosis was most often provided by a neurologist, a pediatrician, or a geneticist. We asked questions about how the diagnosis was received, and all of these questions were based on what's called the SPIKES framework for providing life-changing news to families. And so 69% reported that the diagnosis was given in a clear and direct way. 64% felt that the healthcare provider ensured the information shared was understood, and 75% agreed or strongly agreed that the healthcare provider was sympathetic and understanding. Fewer felt that the provider was hopeful at just 58%, and only 55% felt there was enough time to discuss the diagnosis. Even fewer, only 37%, felt that the provider discussed what their child does well, or is expected to do well. 25% agreed or strongly agreed that they were provided on where to find more information. Only 22% were told how to share information with family members and siblings. And only 46% were scheduled a follow-up appointment to review the diagnosis. When asked what information they want to know but were not provided at diagnosis, parents most often reported internet resources, available family supports, and written information. We also provided caregivers the opportunity to provide written comments related to how receiving the diagnosis could have been improved. Thematic analysis found 3 global themes. The first was less waiting for a diagnosis. There was consistent frustration over delay of testing and diagnoses. Caregivers expressed that their concerns were not taken seriously, and the wait-and-see approach was often distressing. You can see from this quote, "I would have preferred to have a tentative diagnosis of what it appears to be, so I could have been dealing. Rather, I was left apprehensive and concerned about all the problems we were having, trying to catch up and getting more and more concerned about increasing delay." The second global theme was centered around caregivers seeking more compassionate communication when interacting with providers. They often felt they were left without hope and treated without empathy. This quote, "I found that all appropriate people were there, but the diagnosis was provided in a grim and doom and gloom way. I'm sure there is no perfect way to deliver information of this magnitude, and I'm sure they don't want to give false hope, but sometimes hope is what families need. Our son is severely affected, and I still think he deserves hope and positivity and more focus on what he can do. Possibly more of a positive focus would be helpful." The final global theme was around information and support to move forward. Families wanted more information about their child's diagnosis and what could be done to support their child. They wanted to educate themselves. They also reported the supports for parents were needed. It would have been nice to have been given a folder of some sort of contact information for support services and maybe support groups for families of CP, so we could connect and hear other experiences and meet other children with varying degrees of cerebral palsy. I'd just like to acknowledge that this is the work of many people, and I thank all of those people that are listed here on this slide. Thank you for listening.